So we have the last talk of the day for the session, and we have esteemed speaker, international speaker to be part of it. The talk is on the kidney heart failure continuum, lesson from the SGLT2 inhibitor, a case-based discussion, and we have Dr. Javed Butler to present the topic, who is designated his designation as Patrick H. Lehan Chair in Cardiovascular Research and Professor of Chairman of Development of Medicine. He is from the Institute of University of Mississippi Medical Center in Jackson, Mississippi, and had been awarded and recognized for his several national committees of the American College of Cardiology, American Heart Association, National Institute of Heart, and the Heart Failure Society of America. It is indeed pleasure to host you, Dr. Javed Butler, sir, and to your for the topic, the kidney heart failure continuum and lesson learned from the different cases.
Thank you very much. I absolutely have the pleasure of joining this conference. Let me see if this goes up. Great. So hopefully we are now towards the end of our COVID pandemic, and at some point we will be having more of these meetings in person. But I absolutely enjoy the opportunity of talking with you today. So my charge is to talk about SGLT2 inhibitors and focus a little bit more on heart failure. There are so much data coming out with SGLT2 inhibitors that one can literally spend a full lecture on any one of the given diseases, whether it's SGLT2 inhibitors and diabetes, heart failure, kidney disease, mechanism of action. So I will primarily focus on heart failure, but will be happy to answer any questions as we go along. Also, these are my disclosures. Please do notice that I am both a consultant to AstraZeneca and to Boehringer Ingelheim and have been involved in the SGLT2 inhibitor studies as well. So a quick word about why we should be focusing our next 25 minutes or so talking about diabetes and heart failure is because patients with diabetes are at a higher risk of developing heart failure, but once they do develop heart failure, they are at a particularly higher risk of adverse outcomes with it as well. So what that basically means that if you have a person with diabetes, if you can do anything to prevent heart failure, that is really important. But once somebody does develop heart failure and they have diabetes, just realize what a high risk they are at and to treat them very aggressively. And that is shown in this slide that basically if you have diabetes alone, of course you're at a very high risk. But if you have a combination of diabetes with heart failure, your risk of mortality goes up almost by 10-fold. Now, this is a study that came out in New England Journal of Medicine, was a population-based study, and that really sort of makes us fundamentally think about the relationship between heart failure and diabetes in a little bit of a different light. So traditionally speaking, if you look at the Framingham Heart Study days from the 1970s, we have been talking about prevention of cardiovascular disease for a very long time. This is not a new concept. But prevention of cardiovascular disease was implicitly in our mind met prevention of vascular disease, coronary disease, stroke. So it was all prevention of vascular disease. We had Framingham risk score and cholesterol management and low sodium diet and blood pressure control and all of those things. We never focused on heart failure prevention as such for two reasons. First, all the things that prevented heart failure also prevented coronary artery disease. So there was nothing specific about heart failure like blood pressure. Also, the fact that there was an implicit assumption that the vast majority of heart failure is related to or a consequence of coronary artery disease. So of course, if you prevent coronary artery disease, you will prevent heart failure. That is only true for a small majority of the patients, say about 55% or so. 40 to 45% of the patients who develop heart failure do not have manifest coronary artery disease or vascular disease that we know of. Therefore, there is a lot of interest in non-vascular pathways through which one may develop heart failure, and focusing on heart failure prevention by itself becomes very important. So coming back to this study, large study, over 1 million patients, and what they said was that if you take patients with diabetes and they have all 5 vascular risk factors under control: blood pressure, cholesterol, no smoking, no albuminuria, and hemoglobin A1C is fine. If you have all 5 risk factors under control, what happens to the risk of vascular disease? And one can see here that the risk of vascular disease is substantially mitigated. But look at the risk of heart failure. The risk of heart failure still persists. Now, of course, if these risk factors were not controlled, the heart failure risk would be even worse. But the point here is that if you control vascular risk factors, the risk for heart failure is mitigated but does not get abolished, because there are alternate ways by which you develop heart failure. So this traditional paradigm that risk factors lead to atherosclerosis, lead to heart failure is true, but there's a lot of alternate pathways that are also implicated in development of heart failure, and that's where the heart and the kidney links becomes even more important. Let's talk about this in a second. So why are we talking about SGLT2 inhibitors, a glucose-lowering dysglycemic agent, in a talk on heart failure? Well, it all started with the first SGLT2 inhibitor trial that came out, called the EMPA-REG trial, that showed that with EMPA-REG, it was safe for cardiovascular outcomes. That was the primary endpoint, but there was a substantial reduction in heart failure hospitalizations in these patients. The curve started separating early, continued to separate. Now, just one word about the EMPA-REG outcomes trial. This trial included about 7,000 patients who were primarily had atherosclerotic cardiovascular disease. 90% of these patients did not have heart failure. 10% of these patients did have heart failure at baseline. And remember that heart failure was neither a primary or a secondary endpoint. It was an exploratory endpoint. Let's just look at it. And here you see an incredibly robust heart failure benefit. So when this trial came out, it led to 3 questions. First, did this trial just got lucky? There is no heart failure benefit with SGLT2 inhibitors. It's just a fluke. Even on statistical basis, I would say that it will be very difficult to say that this is chance finding, but nevertheless, there was a concern in 2015 that maybe this was just a luck finding, that these results need to be replicated. The second question that came up is that, as I said, 90% of the patients in this trial did not have a heart failure at baseline. So if the benefit is seen in those patients, then you're preventing heart failure. However, if nothing is happening on those patients and all of this benefit is patients who already had heart failure at baseline, the 10%, then we're talking about treatment of heart failure. So what is it? Is it prevention or is it treatment? And then the last question, the quintessential question, why is a glucose-lowering drug having all of these benefits? What is the mechanism of action? So let's take all of these 3 questions one by one. So the first question, there are now 4 large outcomes trials with SGLT2 inhibitors, with empagliflozin, dapagliflozin, canagliflozin, and ertugliflozin. These had different patient populations. Empagliflozin and ertugliflozin were all secondary prevention. People had atherosclerotic cardiovascular disease, whereas DECLARE trial with dapagliflozin had the largest proportion, 10,000 patients, for primary prevention patient population. They had different outcomes, different patient population, but despite of all the differences, one thing which was consistently seen, as is seen here, not only the heart failure benefit was consistently seen, even the magnitude of the benefit was about 30% or so, give or take, was very consistent. So we answered the first question that this was not luck, that this was replicated in different trials. So the second question is it prevention or is it treatment? Well, this is the last slide that I would talk about prevention, and then we'll move on to treatment. So in multiple trials at this point, there have been over 25,000 patients that have been enrolled across trials. And it does not matter whether you have atherosclerotic cardiovascular disease or not, whether you have primary prevention patient population or secondary prevention patient population, SGLT2 inhibitors, dapagliflozin, empagliflozin, canagliflozin, all of these drugs have been shown to prevent heart failure. I will stop talking about prevention here. I'm a heart failure cardiologist. This talk is focused on treatment of heart failure, but I don't want to leave this very important point that the best way to treat heart failure is to prevent heart failure. Now we have a strong agent that, irrespective of atherosclerosis, primarily is targeted in these patients with diabetes to prevent heart failure. And if we can give these therapies to prevent heart failure in the primary care setting, in the endocrine setting, that is the best way that we can manage the epidemic of heart failure. Now let's talk about treatment of heart failure. So all of these trials had about 10-15% of the patients that already had heart failure at baseline. Was there a benefit in here? Absolutely, yes. There was a consistent benefit seen in these patients as well, except that these data are not that clean. So what do I mean with that? Well, with prevention of heart failure, we are talking about 90% of the patient population, strong power, all subgroups consistent, over 25,000 patients. When we talk about those patients at baseline who did have heart failure, it's a small group, about 10% or so. We don't know whether they had heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. We don't know their baseline therapy, whether they were well treated or not. So there's a lot of not known that I would recommend, or I would have said at that time, that there is a good indication that perhaps these drugs are not only good for prevention of heart failure, but treatment as well, and therefore we should study that. So that the third question is, what is the mechanism of action of these drugs? How do these drugs improve outcomes? Again, I can literally spend an hour. The amount of knowledge that we have had in the past 5 years on how these drugs work is phenomenal. Let me just take a 2-minute, very quick overview of all the things that these drugs do. So remember, these drugs were first discovered because they cause glucoseuria. Along with glucoseuria, you lose fluid, so there's some decongestion. There is a short-term effect. But with glucose loss is caloric loss. So you lose calories. So when you lose weight in the long run, you're not only losing fluid weight, but you're losing calories and fat as well. So visceral fat, whether it is perinephric, perisinus, epicardial, or systemic fat, subcutaneous fat, this is a factory for inflammation, oxidative stress, and local adipocytokines, leptin and adiponectin imbalance. When the perinephric or epicardial local fat over the organ goes down, it decreases the risk of arrhythmias, fibrosis, improves organ function. But when systemic fat content goes down and inflammation and oxidative stress goes down, there are either animal data or human data with SGLT2 inhibitors of all sorts of benefit. Endothelial function, aortic stiffness, diastolic dysfunction, left ventricular hypertrophy regression, remodeling, so all of these benefits that you see. Now, SGLT2 inhibitors are coupled with sodium hydrogen exchange receptors in both the kidney and the heart. So when we block the SGLT2 receptors in the kidneys, you also block NHE1 receptors, so you lead to natriuresis. So there is not only glucoseuria and osmotic diuresis, there is natriuresis and sodium and fluid regulation. But in the heart, by blocking the NHE3 receptors, the sodium hydrogen exchange 3 receptors in the heart, that receptor balances sodium and calcium concentrations in the myocyte. So by doing so, you decrease intracytosolic calcium concentration that theoretically can improve diastolic function and reduce the risk of sudden cardiac death. Then there is increased beta hydrobutyrate, there is increased fatty acid oxidation, increased mitochondrial ATP generation, And while I'm going on and on, I haven't even touched the biggest benefit, and that is that these drugs stabilize renal function. Multiple trials have shown, especially with DAPA-CKD and with dapagliflozin, that they improve renal function, which is a big reason for development and progression of heart failure. So to summarize, you have benefits on the kidney, on the heart, on the vasculature, systemically, energy production. The question is not how these drugs improve heart failure outcomes. Of course, there is all of these mechanisms and they work in concert to improve outcomes. The question actually is exactly the opposite, and that is, what does any of this have to do with diabetes? Perhaps these drugs got discovered in patients with diabetes, but if a drug can do all of these things that we have learned now, perhaps these are cardiovascular risk modifying agents, and that these drugs should be used irrespective of diabetes. So as you can imagine, this was a very heavy lift by the investigators to convince the companies that the heart failure trial should be done irrespective of diabetes, and indeed that was done. So there were 4 large trials in heart failure that were started, 2 in heart failure with reduced ejection fraction, 2 in heart failure with preserved ejection fraction, with dapagliflozin and with empagliflozin. The 2 trials with heart failure and reduced ejection fraction have already been presented, and that's where I will focus the rest of my presentation. The DAPA-HF was the first trial that presented the results. This trial is what I call a bulletproof trial. No matter how you slice and dice these data, they are very positive. Over 4,700 patients with heart failure and reduced ejection fraction were randomized irrespective of diabetes to dapagliflozin versus placebo. As you can see, usual heart failure with reduced ejection fraction baseline characteristics, but look at the bottom 2 rows. Actually, more than 50% of the patients, 55% of the patients did not have diabetes, 45% of the patients did have diabetes, so very good representation of both groups. Also, when we live in an era of polypharmacy and the patients are on several medications, what you want to make sure is that the baseline medical therapy is very good. So the benefit that you're seeing is incremental. And you will not find another heart failure trial prior to DAPA-HF that had such well-treated group of patients at baseline. Near ubiquitous use of diuretics, of RAS inhibitors, of beta blockers, all 90+%, 70+% were on MRA. So this was the primary endpoint of the trial. The curve started separating early, continued to separate. The primary endpoint of cardiovascular death or heart failure, hospitalization, or worsening heart failure. There was a 26% relative risk reduction, number needed to treat of only 21. Now, as a clinician, I have to say that I have a lot of inertia in my own practice. If I see a patient, I have a full clinic, the patient is doing okay. So I would say, well, you know what, why don't we talk about maybe changes in some of the medications the next time I see you in 3 to 6 months. Look at this trial, DAPA-HF, and look at the early endpoint. The p-value was significant on day 28. In less than a month, there was a substantial reduction. So not only is it important to give these therapies, we need to really give these therapies sooner because the benefits are really early. Now, the second thing is, did our experiment of using patients without diabetes and calling these cardiovascular risk modifying agent, did that work out? Was that a good idea? And the answer is absolutely yes. Both patients with diabetes and non-diabetes, these 2 curves with one difference, that patients with type 2 diabetes are at a higher risk at baseline. These 2 curves are again interchangeable once and for all, proving that these are cardiovascular risk modifying agents. No matter how you slice and dice the data, there was no subgroup where dapagliflozin was not providing incremental benefit on top of these patients, no matter what the etiology, age, or any of the other characteristic was. Now, sometimes we really get into a lot of these debates. Well, what about if somebody is on MRA or not on MRA or digoxin or ARNI or this, that, the other? Absolutely doesn't matter. These are independent pathways regardless of whether or not you were on any of these other drugs. With dapagliflozin, there was substantial benefit in all of these subgroups. There are more analysis, which in the interest of time, I won't show you today, but not only the classes of drug, but if you look at the combination of drug, whether somebody was on 2 drugs or 3 drugs, or the doses of drug, whether they were on less than 50% of target dose or more than 50% of target dose, none of those considerations matter. Dapagliflozin on top of that improved outcomes further. Both components of the primary endpoint, heart failure worsening or cardiovascular death, was substantially improved. Total heart failure hospitalization was improved, and all of this led to all-cause mortality reductions in these patients as well. There was a 17% all-cause mortality reduction as well. So no matter how you slice and dice the endpoint, the benefit was seen consistently. Now, our patients want to live longer and live healthier, so health status becomes important. Quality of life was assessed by KCCQ, the Kansas City Cardiomyopathy Questionnaire in this study. There are several domains of KCCQ: symptoms, physical limitation, or quality of life. It was measured at 3 months and 8 months, and at all points, all domains were substantially improved. And as we can see here, the responder analysis, the chances of improvement were higher with dapagliflozin. The chances of worsening were higher with placebo ascertainment. This trial had a strong trend with improvement in renal function, did not reach statistical significance because the trial was stopped early because of heart failure benefit, and it did not accrue enough events. We obviously know the data with DAPA-CKD that these drugs have substantial renal benefit as well. In terms of the side effect profile, as you can see, very well balanced all of the side effects. The risk of diabetic ketoacidosis is very low. We have to be vigilant for that. But again, considering the mortality benefit, the risk is very low. The biggest difference or imbalance is genital mycotic infection. So genital hygiene recommendations to the patients are important. And again, when we talk about the issue with hypoglycemia or diabetic ketoacidosis, not only is it very low, of course, those are not issues in those without diabetes as well. So the second trial that has shown now results in heart failure with reduced ejection fraction with SGLT2 inhibitor was the EMPEROR reduced with empagliflozin. And this was a group of patients that were a little bit higher risk, so lower EF, lower GFR than DAPA-HF, was a little bit of a smaller trial. There were 3 endpoints that were looked at: primary endpoint of cardiovascular death or heart failure hospitalization, total heart failure hospitalization, and renal function preservation. And all 3 endpoints like DAPA-HF was met. The one difference between this trial versus DAPA-HF was that the mortality by itself was not statistically significant in EMPEROR reduced than it was in DAPA-HF. We can have an academic discussion about it. My interpretation is that this was a smaller trial with fewer events. I think the data are pretty consistent between the 2 trials. So what is next with SGLT2 inhibitors? We have a lot of trials going on. So now that we have figured out heart failure with reduced ejection fraction, the big question is, do these drugs, will they improve heart failure with preserved ejection fraction? Remember, so far we have no mortality modifying agents in heart failure with preserved ejection fraction, which is 50% of the heart failure burden. So we are really looking forward to the DELIVER trial, 6,000 patients randomized. We should probably get the result. I don't think it'll be 2021, maybe early 2022, but who knows, maybe later in 2021 as well. There are 2 acute heart failure trials going on as well. As you know, when people come into the hospital with decompensated heart failure, they are at a particularly higher risk. So there's one mechanistic trial going on called DICTATE-HF, which is looking at the combination of dapagliflozin with loop diuretics on renal physiology and diuretic resistance. And there is another trial going on, a larger trial looking at longer-term post-discharge outcomes. And then finally, the DAPA-MI trial is looking at post-MI patients and looking at outcomes with dapagliflozin. So lots of data to come. Now, what is interesting is that the reason why I am talking to you not in person, but over a webcam is because of the COVID pandemic. If you look at the COVID infection per se, and I'm absolutely not an expert, I'm not an infectious disease person, I'm a cardiologist, but if you look at a lot of things that are going on with the COVID infection in terms of the vascular dysfunction and in terms of troponin release and BNP and cardiovascular outcomes in patients with COVID, it really begs the question that a drug like dapagliflozin that has so many organ system benefit, kidney, vasculature, heart, energetics, all of which are playing a role in COVID infection, whether dapagliflozin may have benefit in patients with COVID. And believe it or not, there is actually a trial going on called DARE-19, looking at the use of dapagliflozin in patients with COVID-19 infection. So we'll see all of these results. So in conclusion, what we have now proven are two things. One is that these agents are cardiovascular risk modifying agents, and that while I'm going to focus on treatment of heart failure, have been shown to prevent heart failure, and patients with diabetes without heart failure should be given dapagliflozin in primary care setting, in endocrine setting, to prevent heart failure in the first place. But if you have heart failure with reduced ejection fraction, we have now shown 5 pathways: angiotensin 2, aldosterone, norepinephrine, neprilysin, and SGLT2, modulation of which with 4 agents: angiotensin receptor, neprilysin inhibitor, MRA, evidence-based beta blocker, and evidence-based SGLT2 inhibitor, to improve the risk of mortality and morbidity. So this leads to several questions of practical recommendation in terms of the management of patients. So let me address these questions. So one question that comes up is that, is it a class effect or a drug effect? Can you give any SGLT2 inhibitor to patients with heart failure with reduced ejection fraction? I obviously don't know the answer. The only way to know that answer is to do head-to-head trials, which will never happen. So how do you deal with that conundrum? Well, the only thing that I can say is that every time that we have assumed a class effect, we have learned that that may not be true. So for instance, with DPP-4 inhibitors, with linagliptin and sitagliptin, you don't worsen heart failure outcomes. With saxagliptin, you do, and with alogliptin, things go in the wrong direction. With beta blockers, we know that bisoprolol, long-acting metoprolol, and corbetalol improve heart failure outcomes, whereas bisphenols and nebivolol do not. And therefore, the guidelines do not say give beta blockers. They specifically say give evidence-based beta blockers. So my recommendation would be that the only evidence we have right now is with dapagliflozin and with empagliflozin. We don't have evidence with any other SGLT2 inhibitor, especially those that have never been tried. So that's one. The second question is, well, if cost becomes a real issue, which therapy to use? Because in heart failure with reduced ejection fraction, we have been a little bit spoiled because all the therapies were generic. ACE inhibitors and spironolactone and beta blockers have gone generic as well. So again, I think it's a little bit of a Sophie's choice. I would not be able to recommend whether you should use an ARNI or use an SGLT2 inhibitor if you can afford only one. The only thing I can say is what I would do in my practice, and the issue with SGLT2 inhibitors is that it is better tolerated. There are the side effect profile, and I'll come to that in a second, but it is almost a one-stop shop in terms of diabetes control, glycemic control. Remember, there is also reduced risk of new onset diabetes that DAPA-HF investigators have shown, very much similar to metformin. And you have heart failure benefit, blood pressure, adiposity, and chronic kidney disease progression, things that have not been shown with ARNI. So you might want to take that into consideration as you choose. But good medical practice is to give all 4 of those agents. Who to use it for? All patients with heart failure, reduced ejection fraction. Who not to use it for? Well, one is that the GFR tested in DAPA-HF was up to 30, with Emperor reduced was up to 20, not to give it in patients on dialysis, and not to give in patients with type 1 diabetes. Diabetes versus no diabetes is a resolved issue. These are cardiovascular risk modifying agent and should be used in all patients with heart failure, reduced ejection fraction. Tolerability and side effects. So that is the whole saying, like one and done, right? It's one dose. So let's think about it. The reason why heart failure therapy is different is because there is dose titration with ARNIs and beta blockers. And the other reasons, blood pressure, hyperkalemia, worsening renal function, dizziness, none of those are issues with it. It's one dose. Don't get hyperkalemia. If anything, the risk is less. Don't get worsening renal function, and blood pressure reduction in HFrEF trials are not seen. And the last point that I will make is the issue of sequencing. Remember that sequencing is a historical, not a biologic construct. It just so happened that in the 1980s and 1990s, we tested ACE inhibitors, and then late 1990s, early 2000, we tested beta blockers and an MRA. This is historical sequence, not biologic sequence. It doesn't matter in which sequence you give. You have heart failure patients. The bigger question is, how can we give at least low doses of all four agents as soon as possible? Remember, when somebody comes in, and again, I would not recommend starting 2 or 3 medicines at the same time, because if somebody has side effects, you don't know which one it is. What I'm trying to say is that when somebody comes in with heart attack, we start 6 medications: ACE inhibitors, beta blockers, MRA, aspirin, Plavix, and statin, 6 new medication in 2 days. When it comes to heart failure, months and months and months goes on, and I showed you the data that in less than 1 month, there's a mortality hospitalization benefit seen in DAPA-HF. So in 2 to 3 to 4 weeks, if we can at least start low doses of all 4 medications, that's the best way to deal with these therapy. So I will stop here. I will be happy to answer any question. I really appreciate the opportunity to talk to you, and thank you.
Yes. Yes, Asha madam, go ahead, please.
Thank you very much, Dr. Butler. It was excellent presentation, wonderful to hear. And there are now so many avenues for treating heart failure. When we were residents, it was only the diuretics and digoxin. That's all that
Absolutely. That's the era I grew up in. Absolutely.
Yes.
We have one question, Doctor. Yes, we want to go ahead with it. There is a question that in obese patients with CV risk, which drug is better to use, DAPA or metformin?
This needs to go to an endocrinologist.
So there are plenty of audience or delegates who are really keen, and they have not hesitated to ask the question. And if we see this question, we have Dr. Ajay Chaudhary along with ourselves, Dr. Pankaj Shah. So if you can answer, please.
What I would say is there are no outcomes data on non-diabetics that imply that use of any of these agents in otherwise healthy individual who are obese will prevent cardiovascular or anything other than the diagnosis of diabetes. Nothing else is known. So as a group at Mayo Clinic, we don't use any of these agents in non-diabetics or pre-diabetics. I'm sure I'm different from others, but this is what we do, and that is because there is no hard outcome data for any of these agents. And I'm saying otherwise healthy people.
Yeah, I think that's what Dr. Shah says. I'll agree with that. I think clearly now with DAPA and people with heart failure, it's a different story that is coming out even in the non-diabetics. In terms of metformin, if we really look at all the trials, the UKPDS trial had 350 patients, with type 2 diabetes. On the basis of that, we are talking about the benefits of metformin. And there is some discussion now as to if everything remaining equal, whether metformin should be the first drug that we use, even in people with diabetes. There's a discussion going on, I know, and Dr. Butler can also, chime in here about the European Society of Cardiology, having these discussions about whether metformin should be the first drug in people where, cardiovascular disease is so prevalent.
Yeah, so, they have sort of arbitrarily defined patients at high risk and very high risk. So either patients with diabetes who already have atherosclerotic cardiovascular disease or have diabetes for greater than 10 years and risk factors. And then these groups, they are recommending to go with GLP-1 receptor agonist and SGLT2 inhibitor, even as a starting therapy. Again, I don't obviously know the diabetes literature well, but at least in the heart failure literature, what we have learned is that when pathways are overlapping, like say ivabradine and beta blockers, right? So both lower heart rate. So these are overlapping pathways that the presence of one or the other makes a difference. But when the pathways are parallel, ARNI and SGLT2 inhibitors and MRA have nothing to do with each other. These are parallel pathways. Then you get incremental benefit by adding these medications. So you don't have to choose MRA or SGLT2 inhibitor, you combine all that. So with that heart failure mindset, I almost wonder, and I don't know whether there will be ever those studies done, but whether the best way to treat patients with diabetes is actually a combination of SGLT2 and GLP-1, with one most benefits going on the kidneys and heart failure or the myocyte function, and one more with the stroke and myocardial infarction and atherosclerotic benefit.
Yes. Thank you, everyone. And we are at the end of. Yes, Ajay sir, you wanted to share something. Dr. Ajay, do you want to share something?
No, carry on.
Yes. So thank you, everyone. And we are at the end of the session and the whole day. We had the whole tight day, and what numbers came up is at present is more than 4,513 people have logged in and celebrated the whole day sessions. And to add on, we have a special activity area in delegates side, the activity area zone, where the young doctors have made a role play about awareness of diabetic foot, and that we would like to end up the day with that role play. That is 20 minutes. Whoever wants to enjoy at present can be part of over the ending in based hall or the Hagdom hall, or otherwise we can visit the activity area and be part of that role play. Thank you, everyone. Yes, sir.
Thank you very much. Bye-bye.
Yes.
Thank you.
Take care. Thank you, sir. Thank you, Dr. Pankaj Shah, sir.
Oh, thank you.
Dr. Ajay, sir. Thank you, madam. Dr. Asha, madam. Thank you. Take care.